Thank you so much for being here. If you don't know me, my name is Amanda Williams. I'm a clinical nurse specialist in a level 4 NICU here in Southern California. I'm so excited to be here with you. I've become really passionate about certification and certification review. It was actually one of my very first projects as a nurse in like 2015, I think it was. I have been a NICU nurse since 2009, and since I was a new grad, being a NICU nurse was my dream, right? And becoming certified was one of my career goals. And since then, I've gotten 5 specialty certifications, 4 of them in NICU. And so I am a self-proclaimed forever student. I love to learn and I love to teach. And so that's why I'm doing this for you, so I can meet people all over the country, all over the world, and we can kind of learn together. I want you guys to succeed, and I want to just help you as much as I can to help you match your career goals. Oh, yay, I'm seeing stuff. Bay Area, Wisconsin, Pennsylvania. Awesome, awesome. Yay. Welcome. Thank you guys for being here. So this is our agenda for today. We're just going to review a few topics about, I don't know, maybe a couple of weeks ago, I put out a thing on my stories asking what kind of topics do you guys want to hear about. So I took some of those, and I took some just like hot topic requests that people usually want to learn about. We're going to review some. We have 10 questions to review and then kind of go into a little more detail after each question. Hopefully we'll have some fun, and I wanted to share with you guys some resources that I have been creating for you all. So let's get started. Yay. I also just learned all these cool things on Canva, which are so much fun. Let's start. Question number 1. Neonatal side effects of maternal administration of magnesium sulfate include A, hypertonia, B, hypoglycemia, or C, respiratory depression. So I'm going to set a timer, and you guys can chat in your questions. All right. I think most people have answered, and if you don't want to chat it in, you can feel free to like quiz yourself too, have a piece of paper down to ask yourself, what do I think the answer is? All right, and all you that said C, you are correct. So respiratory depression. So let's dig into this question a little bit. So magnesium sulfate. What is magnesium sulfate? So it's one of the most commonly used meds for moms and eclampsia. It decreases contractility. It's a commonly used tocolytic. Tocolytics are meds used to stop labor at least 12 plus hours, so that steroids like betamethasone can be given, especially to our little babies. It's actually kind of interesting. When I was creating this, I found that ACOG actually does not advise for magnesium to be administered for the tocolytic effect, but instead for the neuroprotective effect. So we give it for that neuroprotection because it's been shown to reduce the incidence of cerebral palsy in our small babies less than 32 weeks gestation. So have any of you guys taken magnesium before? Maybe some people take it for sleep. And what kind of side effects or what do we see? So we can see in our babies hypotonia, drowsiness, respiratory depression, and hypocalcemia. So when we're looking at the question, it's asking us those side effects for the baby, right? And notice some little tips and tricks specifically for the NCC exam is that the answer choices are always going to be in alphabetical order. So don't let it throw you off if you're taking the test and the last 5 answers have all been B or they've all been C. They put them in that order on purpose. And now, like I said, think about looking at this question, what does magnesium sulfate do? So right away, we could rule out option A, hypertonia, because we know it actually causes muscle weakness. It's trying to reduce that contraction from the uterus, right? And it makes people sleepy. So even if we weren't sure if it had an effect on the glucose, then we could lean towards respiratory depression based on that kind of sedative and that relaxing effect that magnesium has. Does anybody have any questions? Oh, it's okay. Any questions about that one before we go to our next question? Good job, guys. All right, question number 2. I think one of everybody's favorite things is blood gases. So let's analyze the following blood gas value. We have a pH of 7.11, a CO2 of 65, and a bicarbonate of 17. Do we think it's compensated metabolic, uncompensated metabolic, uncompensated mixed? How do we know? Okay, awesome. All of you guys said C, which is great. You are right, but let's break it down together. So how do we know? So I like to, there's a lot of different ways people will calculate blood gases and decide whether it's metabolic or respiratory, compensated versus uncompensated. And so I like to use arrows just to help my brain. So I put here our normal values, and then this was our guess from the question. So first of all, our pH is low, right? It's acidotic. And anytime the pH is not normal, that means it is an uncompensated blood gas. So right away, we can cross off A. We know that it's not compensated because the pH is 7.11 and our normal is 7.35 to 7.45. So yay, we already knocked out one of the answer choices. Then we are looking at our CO2. So our CO2 is high. And always remember, carbon dioxide is the respiratory component, right, of our gas. And carbon dioxide is an acid. So if there's a lot of carbon dioxide, that is contributing to the acidosis that this baby is having. So we definitely know, because our CO2 is high, that there is a respiratory component to this blood gas. So with that, we can cross off answer number B too. So look at that. We already narrowed it down to our right answer, but let's continue to talk about our bicarb. So our bicarb is low, and bicarb is a base. So again, if we don't have a lot of base, that is also contributing to the acidosis that this baby is having. So our baby has a mixed respiratory and metabolic uncompensated acidosis. So you guys all got it right. It's C, right? Do you guys ever have trouble trying to remember like high versus low? What does that mean? How do I know?
No.
No, you guys are great. Awesome. Either way, I'm going to tell you some little tricks so that I have learned, although there's a lot of different tricks, is you can think of ROAM as an acronym of how the carbon dioxide or the bicarbonate affects the pH. So respiratory, opposite, metabolic, equal. So if the CO2 is going the opposite direction as the pH, so the CO2 is going high and the pH is going low, then you know that that is a respiratory acidosis. There's a respiratory component to our acidosis. If they're going the same direction, then there's a metabolic component to the acidosis. So low pH and low bicarbonate, we have a metabolic acidosis. Does that make sense? I highly, highly recommend that you guys practice your blood gases at work. When you're drawing your blood gases, determine, is this metabolic, is this respiratory, what's going on, and try to predict what your team is going to do. What is the next step for that baby's blood gas? So great job, you guys. All right, let's move on to question number 3. So you're obtaining labs for a newborn who was born 2 days ago. Which of the following elevated lab values indicate physiologic hyperbilirubinemia? So is it elevated glucose, elevated direct bili, or elevated indirect bili? All right, so what is the answer? It's C. And this is another, all 3 of them have been C's just by chance because of the alphabet. So this is looking at physiologic jaundice. So what tells us that there is a physiologic jaundice? So real quickly, let's review bilirubin and bilirubin metabolism. So you guys know that bilirubin is the metabolic end byproduct of red blood cells. So when red blood cells break apart, then it releases heme that binds to albumin and it's transferred to the liver in an unconjugated state. The unconjugated state is fat soluble. And in that state, it can cross the blood-brain barrier when it's at very high levels and it's not easily excreted. So once it's carried to the liver breaks it down and it metabolizes it so that it becomes conjugated. And when it's conjugated, it's in a water soluble state. When it's in that water soluble state, it's able to be excreted into the bile duct and into the intestine, where the vast majority of it, 98%, is excreted into the stool. Now, we see the majority of newborns, whether they're in the NICU or they're in the postpartum area, the newborn nursery, they have some degree of hyperbilirubinemia right after birth, right? And for most term babies, this is a physiologic jaundice caused by increased levels of the unconjugated or the fat soluble bilirubin. It just takes some time for that liver to start understanding how to process all that bilirubin. And it's usually a self-limiting thing that sometimes doesn't even require any treatment at all, just requires monitoring and for that baby to kind of wake up and start to excrete that bilirubin. So it occurs after 24 hours of life. So this is physiologic jaundice and peaks at 3 to 5 days in our term babies. And then it usually resolves by 1 to 2 weeks of life. Sometimes the babies might need a little bit of phototherapy to lower those bilirubin levels, but physiologic jaundice, it's important that we differentiate it from pathologic jaundice, which is associated with the even higher level of unconjugated bilirubin. And when it's that pathologic hyperbilirubinemia, we see elevated total serum bili and elevated unconjugated or indirect bilirubin, right? When we see the elevated direct bilirubin, we become worried about things like cholestasis. So we'll talk about that at another time. But with this one, I really wanted to focus on physiologic bilirubin. And when we order that total bili, which you guys probably see a lot when you do your serum bilirubins, it has the 3 components, which is the indirect or the unconjugated, the fat soluble, the direct, which is the water soluble, and the total of the 2, right? And what we see in our baby is that jaundice, or it can also be termed icterus, and we're trying to prevent bilirubin encephalopathy. When that unconjugated level gets so high, it can cross the blood-brain barrier and actually cause neurologic effects. And the worst of it is kernicterus, which is considered like a never event. So what increases the risk of pathologic hyperbilirubinemia? So some of those is hemolysis. And one of the big things that we think about with hemolysis is our ABO and RH incompatibility. So I put up this chart, and I always think it's helpful for ABO, at least, that you see mom is type O, and so the O in mom, and then the baby is type A, B, or AB. And basically that helps me to remember which one is which for ABO incompatibility. And then there's RH incompatibility, where it's RH negative for mom and RH positive for babies. And we can also look at the antibody test to see if any antibodies are present, which will accelerate hemolysis. So our direct antibody test looks at the presence of antibodies on that newborn's red blood cells, whereas the indirect will look at antibodies in mom's blood, and that can help identify problems either during delivery if she needed a transfusion, or we can help us predict any problems with the baby. Is that helpful for you guys? Quick little review. Oh, I love the heart eyes. Thank you.